Good afternoon, everyone, and thank you once again for joining us. This is the Nigerian Association of Medical Physicists, and we host a webinar monthly, every second Wednesday of the month. Thank you once again for joining us. Today, as always, we have an interesting topic that will be delivered by one of us, a member of this great association, Mr. Adedotun. And he will be speaking today on the topic, a day in the life of a radiology physicist. So we started a series to create awareness on the roles and responsibilities of medical physicists in the various specialties. So last month we looked at nuclear medicine, and today we are going to be discussing what physicists do in radiology. So I'm going to quickly introduce Mr. Adedokun before he speaks. Okay, I believe you can all see my screen. So Mr. Adedotun is a skilled medical physicist with a decade of experience spanning oil and gas, radiotherapy, nuclear medicine, and diagnostic radiology. His core expertise lies in diagnostic radiology, where he focuses on image optimization, radiation protection, and quality assurance to enhance patient safety and diagnostic accuracy. He's passionate about advancing safe and effective imaging practices, and he actively collaborates with healthcare professionals to implement robust radiation safety protocols and cutting-edge technologies. He's dedicated to fostering knowledge exchange within Nigeria's medical physics community, and he welcomes opportunities to engage with peers on innovative solutions in the field. I would like to also mention that, so as you can see from the poster, Mr. Adedokun is currently a senior. Can you please mute your, somebody is interrupting this transmission. Okay, so as I was saying, Mr. Adedokun is currently a senior radiological physicist at the Imperial College London. But I would like to also mention that before he moved over to the UK 2 years ago or last year, he worked here in Nigeria. He was once a staff of the University College Hospital, and also the Evercare Hospital in Lagos. So, Mr. Adedokun, thank you for agreeing to be our guest this month. And I formally hand over to you to start your presentation. You can please share your screen.
Okay, good afternoon, everyone. Thank you for having me. Please confirm you can hear me, please.
Yes, we can hear you.
Yes.
Okay, great. So I'm going to go ahead and share my screen. Okay, so can you see my screen now?
Yeah.
Great. Thank you, everyone, for joining in, and thank you for the opportunity to present, just to share what I believe is a passion. And I believe I should be able to talk like the introductory speech by Dr. Wadiai, as rightly said. I worked in Nigeria all my life, so moved to London just about less than 2 years ago. So I still have an idea of the struggles and the things I face, practicing in Nigeria. And I mean, this talk at some point might get quite passionate. So please just bear with me, and let's just keep it as interactive as possible. So I'll be talking about a day in the life of a radiology physicist. Now, like we know that there are various branches, maybe 4 broad or 5 broad branches of medical physics. So we would have the physicist that specializes in nuclear medicine, in radiotherapy, in radiation protection as per maybe oil and gas, agriculture, and other things. We have physicists that are pure university lecturers, researchers, and we also have physicists that only specialize in diagnostic radiology. So I'm going to talk for some pure benevolence. I've been able to see almost all of the feeds, which I count as a very rare opportunity. But now I'm actually local in DR. So when I say DR, I mean diagnostic radiology, and that will be the basis of this presentation. So I know diagnostic radiology for me should be basically what we should all understand, because it looks to me like it's the basis of whatever we do in medical physics before you begin to go to radiotherapy and nuclear medicine and other things. We all must have seen X-ray at one point or the other. So this morning, I'm just going to be sharing with you a few of how I spend my day, and also a few of what I believe DR physicists should be doing, and maybe some other scenarios, and then we'll close. So we'll talk about the overview, the key day-to-day task, and important skill set for a DR physicist, and then some challenges. Now, these challenges might be a bit outdated, but as per my experience, I have put some things together. So officially, I'm starting now. So thank you so much, everyone, once again. And thank you for NAMP. You guys are doing a very, very amazing work. The ESCOs, everybody, and my very dear friend, Dr. Yobosa. I would respect the fact that you are the NAMP guy here, so I won't go beyond my boundary. Okay, so but I mean, she's been an amazing friend. So when we talk about diagnostic radiology, these are what I believe all of us should be familiar with. So in diagnostic radiology, what are the equipment that we would see? So we'll talk about general radiography. So when we talk about general radiography, we're looking at the general X-ray, maybe the wall-mounted or over-couch systems, which is common. Maybe the mobile X-rays, DEXAs. You're looking at the computed radiography, the CRs, and the rest of them. Generally, those are what we regard as general radiography. In fact, in the UK, we usually call it generals. Like if you say general rooms, that means you're referring to just a plain film or just an overcouch room. That's what we mean. So it could be mobile, it could be fixed, it could be DEXA, it could be any of these ones. Then fluoroscopy, in terms of your cath lab, your endoscopy, all of your cardiology units, where you have the biplane, the single plane, mobile image intensifiers, and the rest of them. Computed tomography, yes, we know that. Mammography units. Then interventional radiology will go hand in hand with the with the fluoroscopy units. And then we have dental imaging also, still under the purview of diagnostic radiology. So dental imaging could be just your plain basic dental x-rays, could be cone beam CTs, OPGs, and the rest of them. So that is typically what I believe, those are the equipment. As per equipment, those are things I believe a DR physicist is going to be covering. So this slide really just tells you about how I spend my day, really, as a DR physicist at Imperial. So first thing first, I like to start by checking my calendar to see what I have planned for the day and prioritize them. It's so easy as physicists because just a single phone call can actually change your day, can change your everything you've planned for the day. So it's good as a physicist to be so organized. And I must say that there is no typical day for a physicist, because it's not like, oh, I have to see patient, oh, I have to do this equipment, oh, I have to do this. You're just there to support everybody. You're supporting the doctors, you're supporting the radiographers, you're supporting the university, you're supporting research. So, I mean, you can't really dictate how your day will go, but of course you should have a plan. So I normally will have everything put on my calendar. If I have anything booked, QC, lectures, anything, I like to put everything on my calendar to see which of these meetings I want to attend, which of these things I want to do, and then I'll prioritize them right in the morning. The next thing I do is to confirm if all daily radiographer QCs have been done. It is important, and then send a reminder if it is necessary. So it's easier for me. I'm going to take this point 2 and point 3 together. Also, the QC database for my own equipment as per physics QC. I check this database and I try to see what has been done and what has not been done. It's easier because I have a database where all of my equipment, the inventories, their status and everything is active. And, you know, I have something similar while practicing in Nigeria, and that was it's something you could do just with an Excel, even though here, you know, IT and everything is super. So we have like a full-blown database where we track and see all of these things. But even with Excel, you could do, if you're so good with your Excel skills, you can actually do your database to see which of the equipment, for example, maybe you run your QC twice a year, or maybe once a year as per the regulation or as per the protocol you have. You can have them to notify you 2 months to the time where you're going to be doing the QC, and then, or you could color code them and see if you've done it. It could be green. If it's about to be due, it could be orange, and if it's already due, it could be red, and you know, stuff like that. So you can have that database. So you need to check that to see, oh, what is due, what is going to be due, do I have the right equipment for what is due? Then radiographers QC is also important, and we're going to talk about that also just in a moment. I check the dose management system to confirm servers are active, all the doses for every procedure is going to the servers, talking about the packs, talking about the radiology information services, talking about the dose management systems. That's what I do. You also want to check the patient incident server. So we have another database where every patient incident go into, for some reason, radiographer has repeated a scan due to maybe mistake or due to error, maybe in patient identification, in laterality or anything like that. They notify physics, and then you have to do the calculation for them. So you also want to check. So if there's any incident, there are new incidents maybe that came in overnight. You know, radiographers work round the clock. So that came in overnight, then you want to check if there are anyone. Some might be urgent. You can have patients waiting to see, oh, you have exposed me unduly. What is the dose I have and stuff like that. So physics, you have to do all the calculations and all that. So you want to also check if you have lectures for students, for radiographers in other sites, for physics trainees. I also check if there are new research studies. For every research study that involves ionizing radiation, as a medical physics expert, you must calculate the dose to the patient, to the participant, whether it's members of the public, whether it's patients. Even if they are patients, you want to be sure, is the exposure going to be part of their routine clinical pathway, routine point of care, or is it going to be additional to them? So you must check all of this. So we have like different things for that, where you have different channels where you check and see what is waiting for my attention. Of course, like a day like today, you have meetings, you have webinars, you want to also attend, and the rest of them. And then I also do clinical procedure observation, because I noticed that it might be quite easier to support, especially interventionists, when you have an idea of what they do. So maybe majority of us just I mean, sometimes you just hear stenting, you just hear catheter ablation, you just hear atrial fibrillation, nodal ablation, and stuff like that. You don't really know what these guys do and you are supposed to support them, because if anything goes wrong in the process while putting in the, everything, as long as they have radiation equipment with them, they're using the fluoroscopy unit, which is emitting radiation, you want to be able to support them. Somebody had just, for some reason, some doctors, some consultants will not just wear their badges, and you just want to know, you want to be able to estimate what is the dose to them. You want to also see, so I put it, even though it's like, it happens like once a month, I like to see clinical procedures just to appreciate and see how best, so that when I'm giving, oh, don't do this as a doctor, don't do this as a radiographer, I'm not just saying it as a physicist, I'm saying it because I know what they do in the theater, so I do that also. So these are my key day-to-day tasks. QA/QC, like we know, will form most of the job we do, and that's practically forms about 40% of what we do. But I'm just basically, I could say all of the job I do can be grouped into these 5 major sub-heads, like that. So let me talk about the QA/QC first. So like I said, as a good physicist, so now I'm deviating from what I do to what a DR physicist should be doing. So as a DR physicist, you want to create a database to track your QC. It is important you know which of my QC. Sometimes can be very overwhelming if you are in an institution like Imperial, or like, let's say, University College Hospital in Ibadan, where you've got all of the equipment and everything. Can be quite overwhelming, and you must know all of the equipment that are under my purview. If anything emits radiation in your facility, it automatically comes under your purview. And if it is used for diagnostic purpose, as a DR physicist, it comes under your purview. So except for maybe they use it, maybe you have physicists looking after that equipment. So in radiotherapy unit, for example, you might have, let's say you have a mobile II for the purpose of dose planning, or you have a CT for the purpose of simulations. Yes, the physicists in radiotherapy, the radiotherapy physicists can be looking after those equipment, because of course they are physicists themselves. So, but anything other than that, as a DR physicist, anything that is used for diagnosis, you must look after, as long as they give radiation. So you want to track the QC. You want to be sure that nothing goes into the crack. You want to ensure that you are monitoring, and then you're doing your QC as per when due, because if you don't do it, then you won't be able to know the status of your equipment. You want to follow up on repairs, routine maintenance, and keep your inventory up to date. One equipment has been moved, one is out of service, one is ready for service. For every preventive maintenance, I don't know how many times you have that. I mean, it could be planned, it could be unplanned. Then you want to be sure that you follow up as a physicist to see, oh, what is this equipment? When you have an equipment that is down, I mean, as a physicist, you should know that, oh, this particular mobile X-ray is no longer in use, and then you put it out of use. If you run a QC on an equipment and you have put it out of use, you want to be sure that whoever is going to work on it is working on it. Also, as a DR physicist, I said ensure physics checks are done every time any job that impacts radiation pathway is done. So maybe they've come to change the collimator, they've come to work on the tube, they've come to work on the generator, they've come to do anything that impacts radiation, no matter how little, even if it's just about changing filter. You want to be sure that, yes, you follow up, and then you run at least a minimum QC to be sure that everything is ideal before it is put to clinical use. Train radiographers to perform daily QC. There is no way as a physicist you want to do daily QCs on all of the equipment. In fact, as per regulation, if you're using IPEM, for example, there are QCs that are meant for radiographers. For example, generator checks. It should be a weekly thing. It could be bi-weekly, it could be monthly thing, but this should be checked by the radiographers, because they are the end users of this equipment. You want to be sure that they run the generator test, the C, the constancy test, the KV accuracy. You want to be certain that, yes, the KV is still as accurate as possible. They can't wait for once a year when physics is going to do the check. They do minimal image quality test also. When you train radiographers, you are just helping yourself. You don't literally, they're not taking your job, you just tell them, and then when anything they measure, the essence of the radiographer's QC, the essence of QC in the first place is that you want to discover any fault, any malfunction before it becomes clinically noticeable. All right. So when a radiographer has done maybe the AEC chamber test and they discover that one of the AECs is not giving the right time or something or dose, then they reach out to physics, and then you go there and then you intervene. And then you try and troubleshoot to see what the problem is. If you don't know, then you call the radiographers to say, I know this thing is out of spec, come and do the job. Ensure your recommendations are followed and you have a good relationship with radiographers. One of the rifts I experienced as a practicing physicist in Nigeria is that from doctors to radiographers to physicists, we have this, no, you can't do this, no, this is my job, that is your job. You need to have a good relationship with them because they use the equipment. They are the one to book you. Oh, I have a QC done, that I have a QC that is booked. They are the ones seeing the patient. You don't understand the workload they go through. They don't understand what we see. We need the equipment to be good for them and also for we are here for them and also for the patient. So you want your recommendations to be followed. You want to have a good relationship with them. You want them to be able to say, okay, I think from this time to this time, we won't book a patient, and then you can come and run your QC. Have a predetermined remedial and suspension level. As a good physicist, as a good DR physicist, you should have, at the point when you do your acceptance, you do your commissioning, it is important that you have what you call remedial levels, where maybe when some measurements are out of specifications, you can still, while you ask the engineer to come and work on them, they can still use it for clinicals. But when it goes beyond a certain, it could be 10% from baseline, it could be 20% from baseline, then you have a suspension level. All of this makes you a physicist. And then you can check for, if you don't know what remedial or suspension levels you could set, you could check IPEM, you could check AAPM, you could check American College of Radiology, Royal College of Radiology, ICRP. They have guidelines there for you as a physicist. Then you also need to work with application specialists. Don't expect too much from them because majority of time, apps are usually radiographers, but you can, because they know the equipment so well, you might want to really try and work with them to put anything that is out of spec. As a physicist, you are not there to, oh, I must fix every fault. Oh, I must solve every problem. If you understand it and it's within your purview to solve, you solve. If it's something that you think you don't know what is going on, there are times when you don't actually know, sincerely, you don't know what is going on, then you call but what you know is that this equipment should give this. You're setting your equipment, your mobile X-ray, for example, on a 70 kV and a 5 MAS, and on your dose meter, you're measuring 78, 79. That is beyond specifications. You might not be able to fix that as a physicist. There's nothing you're going to do. You won't carry screwdriver and unscrew the system. Then you need to tell the whoever the engineer or the application specialist is that this, before we can put it to use, you have to bring the KV within this range. Another thing I find very interesting here is the radiation dose management. It is important that a clinical physicist have an idea of the dose for any given procedure. What is the dose for chest X-ray, for abdopelvis, for all of that? You must have an idea. What is the dose for any given procedure? And while from your advice, all radiographers are expected to record these for all of the patients. So here in the UK, we are big on DRLs. What are national DRLs? These are just dose benchmarks for flagging unusually high exposures. Benchmarking dose distribution across facility, you're able to compare from one facility to another. You have 3 Philips equipment. You can see for chest X-ray, one is giving a DAP of maybe a dose of 0.04. The other one is giving a dose of 0.08. Why? That's like double. What's the difference? You need to know why. Maintaining image quality with minimal radiation. So just for an example, so the DAP for a typical chest PA in the UK is 77 milligray centimeter square, which will correspond to about 0.01 millisievert in dose. Now, if Dr. Yobosa should check the slide that I sent to you 2 days ago, I put there 150 milligray centimeter squared. Why? Because just yesterday, the national body, the UK, has actually released a new guideline that has brought down the chest PA to 77. So what does that mean? As a physicist, you need to be up to date. So that means that any typical, DRS is about typical dose. It's not a dose limit. It's about, okay, for an average, for a typical size patient, in Nigeria, we say 70 kg, what should be a chest PA for a typical sized patient should be around this. So as a physicist, you're able to look at it and say, okay, what is my equipment giving and how can I make it better? Because definitely they have done a nationwide study and most of the equipment, 75th percentile is going to give this. So your equipment can either do it or at least do something close. Most modern systems, like in Nigeria, most modern systems will have a DAP meter. And that is what you see for every exposure you make. You're going to see a reading on your screen that will be in either microgray meter squared, milligray centimeter squared, decigray meter squared. That is your DAP. And then you need to record that for every equipment, for every exposure. Radiographers must. In the UK here, in Nigeria, I think is a good thing to do. And then if your equipment does not even give DAP, then you can get a DAP meter. I've put a picture here, which is this one, and that is a DAP meter. And you can actually, incorporate this and it measures your DAP for you because it's so easy to calculate your DRL. Your DRL is either based on DAP or is based on entrance skin dose. So if you don't have a DAP, then it becomes a bit more cumbersome, but not so cumbersome. If you know the irradiated area, if you can tell what the field size for your exposure is, then you can, from the tube output, you must have calculated during your QC what is maybe the entrance skin dose for a typical size patient. You can use a phantom for that. You can do that. If you don't have that, then you might have to use maybe a TLD or a ionization chamber on the patient, which might be a bit discomforting for the patient. So once you have your entrance, I think one of the easiest things for us to measure as physicists is the entrance skin dose, is the tube output. We have your dose meter. You can measure easily your air camera. That is so easy to measure. You have that in milligray, and then you can actually multiply that by the feed size. That gives you what your DAP is going to monitor. So you can't do that manually. It is possible manually. So like I said, patient comes in varying sizes and weights, so your DAP is not going to be the same for all the chest PAs. But if you collate all of the values, then you get your 75th percentile. That can be your local DAP. So you don't have to wait for Nigeria to come up with an NDRL. In quote, you can have a DAP, because even in the UK, for every room, there is a DRL, so which is called local DRL. So you can have your own local DRL, which is going to guide your radiographers. So for every exposure that goes beyond that, they should notify you if there is no clinical reasons. For example, maybe a bariatric patient, a big patient, for example, you know that you have to jack up the KV, you have to jack up the MA for a big patient. That is reasonable. But for an average size patient, you don't want to double and triple the dose. Sometimes equipment can be erratic. So you want to monitor all of that. So, yes, so like I said, DRL will differ from room to room. A physicist must be informed if the reference value is consistently exceeded, and then you want to ensure that you have that DRLs handy for the radiographers. And good optimization projects are only possible with DRLs. If you don't have a reference level, if you don't have a reference value, how do you do optimization? How do you improve on optimization? What is the goal of optimization? You want to keep the image quality okay, and then you want to bring down the dose. How do you do that? when you're not even sure what that is going to be doing, you don't have a reference value, that might be a bit tricky. So another thing we do is clinical integration. It is important that you are integrated and you support the whole operation. So clinical physicists are relevant every day in a diagnostic facility, from radiographers QA to artifact and image quality issues after acquisition. There are many things doctors won't understand. Yes, you can't blame them. There are many things radiographers won't understand. In fact, as a matter of fact, as a physicist, you know the equipment more than a radiographer. Yeah, that's very important. And that's one of the struggles I had when I moved newly into the UK, because while in Nigeria, I do QC in conjunction with the radiographers. So you can tell them, oh, they can set up for you, they can just tell them the KV, tell them the MAS. But here in the UK, you work independently. While you're QAing, nobody's there with you. You're there all by yourself. You put on the equipment, you put in the... As a matter of fact, even as physicists, you have a senior level administrative password than the radiographers, so that you can go into many modes that they can't go into. You can change everything because you have the final say as regarding radiation safety. Incidents also, like I've said earlier, we could have issue of incidents for some reason. Patient was referred for right shoulder. The radiographer has imaged the left shoulder. You don't just allow the patient to go. You need to calculate what is the extra dose from that. And you have to tell the patient. That is duty of candor. That is the right thing to do. Reporting monitors. This was very strange to me also when I got here. I don't know, there is a whole loads of QA as prescribed by the IAEA and ICRP, IPEM for reporting monitors, because everything might be okay if the monitor the radiologists are using to report is bad. The pixel values, everything is terrible, then all the work will be put to nothing. So it's also important for physics to monitor, and these things are so easy to do. Unusual exposures, yes, they might want to call you, they have an unusual patient. For some reason, it's a novel kind of imaging. They want to see your opinion. They want to see if they can go ahead with it. Dose estimation to a patient, also I've mentioned that. Then litigation and medical legal reasons. If a patient is suing the facility that you have unduly exposed me, a patient maybe for some reason was pregnant, they didn't know, and then they have exposed the abdomen of this patient, and this patient is suing the hospital. How do you tell what is the dose to the patient? Everything. They would need, even for the case to fly, they would need your write-up as a physicist. Yeah, I'm going to round up very soon. So I just put like just a scenario example. A radiologist is calling to complain about the IQ in some abdopelvic scan. The images appear too grainy. The correct protocol has been selected. Patient was well positioned and equipment is functioning optimally. As a physicist, you have just been called. What are you going to do? So for investigation purpose, you want to ensure that the scan parameters is correct. How do you know? Because you have a protocol. As a physicist, you must have the copy of all of the protocols that you use in your facility, whether for chest, for head, for neck, for shoulder, for knee, for foot. And then you want to compare that every time there's an issue. You want to be sure, okay, the scan parameters are correct. The right KV has been selected. The right protocol has been selected. The right filtration has been used. Tube output and QC logs, they have not flagged anything. System was functioning within expected specification. But for me, I can also look at the image. There's something we call the DDI, or the exposure index, that will tell you about the signal to noise ratio on that exposure, But if you notice a significant drop in your image SNR, then you can tell that something is blocking the radiation. Something has happened between the exit of the radiation from the tube and the detector. Then you can tell. So, and from there, what is the problem? This is something that actually happened in my trust. And I just discovered that the radiographer has accidentally pressed the filtration button that is on. And for some reason, you do know that these radiographers, they've been using the equipment for years. They do not even know what that button is. So that button is actually used to add like extra filtration, especially when we do chest x-ray, you want to put like an extra filtration of 0.1 millimeter copper. So they've just pressed it while setting up the patient, while moving the head of the tube, and accidentally she's pressed it and nothing will flag it. And that was why many, and probably the person that pressed it like maybe 3-4 days ago, the radiologists were just struggling to report, and that was how we were called. So that is just a practical example of, as a physicist, how you are so integrated into the system. Research is also quite important. Training is important, and education is also very key. So all research proposals involving X-rays must have the physicist input. That is a law. Radiographers' continuing education program, we want to ensure that you're keeping them up to date. Your radiographer, you are at peace when you have a very good hand handling the equipment, exposing the patients, people that understand optimization, people that understand ALARA principle. Then also you want to find time to also train postgraduate and clinicians. But beyond this, you want to also mentor young physicists. This is very, very important. Young physicists are not coming to compete with you. As a matter of fact, they're coming to complete the assignment. So as a good physicist, you must find time to always, when people reach out to you, I need help regarding this, like in Nigeria, I don't see why you want to commission an equipment, let's say a CT equipment that is, that the commissioning will take about 7-8 hours. There is no reason for you not to bring in maybe other physicists if you can, people that have more experience than you, setting up the baseline together, doing all of this work together. There is nothing wrong in that. I mean, as long as within the ambit of what you are permitted to do. So mentor young physicists, that I cannot overemphasize. It is very important. While I started, I left the University of Ibadan when I finished my first master's degree. I was employed, I was bright as a student, but I honestly don't know anything when it comes to radiation safety, when it comes to QC. And somebody gave me a chance. I'm glad Dr. Oshegun is on the call. I mean, she gave me a chance. She allowed me, she trained me, she introduced me to all of these things. So, and from there, having to build one way or another, going on and on like that. And then she's still mothering me even up till now. I think for me, and that is why for younger folks on this call, maybe some of them have reached out to me before, I am always happy to help anytime, any day, because I know that these things, they are not as abstract as we think. It's just because of exposure. If you have the right exposure, you're going to do very, very beautiful in the field. It's not a crime that you don't know many. You can't know them because you're not so familiar with them. They will teach you in the classroom and all of that. I've got people that have impacted meaningfully to my life. So it is very important, especially as physicists, ensure you have people that you are also teaching, that you're also training, that you're also showing. Unfortunately, I was discussing with Dr. Wadiaye at some point. I reached out to somebody when I came into nuclear medicine newly, and I reached out to someone, and the response of the person to me wasn't so great. And I was like, eventually, if you don't teach people, they will still find a way to know if they have the right inquisitive mind. They will still find a way to know, and just going to be like that. Radiation protection training, we also do this. That is also very key and very important. We should have time to train people in your facility on radiation protection. This might not be your job as a core clinical physicist, but if you have a radiation protection officer, or if you double as a RSO or something, you want to also find time to do that. And then you want to update yourself. You want to keep your scientific knowledge up to date. Equipment procurement and commissioning. I see this doesn't happen every time in Nigeria, but here it is very key to what we do. You have to be aware, you have to be relevant, and you have to be technical in your facility. I put a scenario here. Your hospital procurement officers reach out to you for that a new cath lab is underway. 3 OEMs are bidding, Philips, Siemens, and GE. How will you screen the vendor? How are you going to tell who is the right person to give the job? Now, the 3 of them, you have asked for their technical documents or their white paper, as the case may be, on the equipment they will be supplying. And these are the information they have given you. As a physicist, which of this equipment are you going to choose? You can put on the comment section in the chat box where which one you can choose, just for an exercise. I mean, look at Philips, look at what it's offering, look at what Siemens is offering, look at the cost, look at what is offering, look at the GE. Which, as a physicist, which one are you going to take? You need to know what frame rate makes sense for my patient. One is giving 7.5, that's the minimum. One can go as low as 3 and can go as high as 60 frames per second. And, one is 1.2 million, one is 1.1 million, one is 1.3 million, all of that. They all have a low dose mode. One also have a dose tracking system. And look at the image matrix when it comes to image quality, which one offers the image quality. Look at the upgrade pathway and all of that. Those are the things you should consider as a physicist to say what will inform my decision. Because if you don't give them a technical advice, I know that political and everything is still going to play out, but at least you should give your input. They should know that, yes, if you're buying a radiology, it's not good, it's not great when you are just called to come and commission an equipment. You don't even know when they're buying it. You don't even know who is supplying it. There are many, without prejudice to China, there are many equipments that they are terrible for your patients. They will make your life miserable as a physicist. There are things that they know what they do. They won't supply those equipment to some countries, but they want to bring it to you. They want to dump it at your door. I've gone to see equipment that are 10 years old and they've been supplied as new. 10 years old, and then they are supplied as new, because you would know, because every tube has a serial number, just like every radiation source has a serial number. So on the database, you can see when that tube was actually manufactured from the serial number. So as a physicist, you will know. So, I mean, I don't know what is going on in the chat, but I know majority of people are putting stuff there, if my assumption is correct. So, but Siemens will be the best option as far as this technical details is concerned, because you want to go with the best image quality, you want to go with the best dose management system, and you want to go with the best upgrade system. So important skill set quickly before I round off and allow us to discuss, ask questions. For me, radiation physics expertise is no brainer. You must know your radiation physics. You must know your radiation physics. This is very important. Data analysis, what can you do without data? Is everything you do, talking about your generator, talking about your constancy test, your linearity test, everything is about data. Knowledge of standards and guidelines. You can't, there is nothing, you can't trade it for anything. Knowledge of your standards, you need to know what is NNRA saying right now. What is IAEA saying? What is ICRP saying? What is their last technical? Do you have technical documents? You have technical DSS and all of them. So you have them to use. Soft and interpersonal skill, I'll say communication. Be a good communicator as a physicist. You need people to understand what you're saying. Have a problem-solving mind, because sometimes it can be sometimes nobody knows the solution. Doctors don't understand it. Radiographers don't understand it. Even the application specialists don't understand it. They just want physics because they know you know more. Of course, ethics and integrity. If you don't have integrity as a physicist, come on, you're going to mess things up, right? Because everybody will be looking up to you like, what does physics have to say in terms of this equipment? And be under pressure again, and equipment is out of specification. You can put do not use on the equipment, and it must be respected, and you have to do that. And then when you have a lot of people on your neck to say, no, that equipment must be ready to use, then it might be a bit challenging. Bonus skills, if you understand AI and machine learning, is great. There are many things you can do with that knowledge. And then I'll say humility. As a physicist, you have to be humble. I've put it as a bonus skill. I mean, you might choose not to be humble if you want. But I think as a physicist, no matter what you know, because we keep learning and physics is so evolving, and you must be able to, reach out to people, let them explain to you what you don't know. As a physicist, sometimes we work independently, and then you have an equipment to commission. You don't even know how to commission the equipment. You don't even know how to do a normal QC. And then you want to just, mask it and just do it. Why not reach out to people that can do it and say, oh, sorry, can you support me? Let them say no if they want to say no. But I think a good person will want to support you. They can find time. They can, these are some of the things I think they are quite important as a DR physicist. Now, the challenges, maybe it's outdated, I don't know, but I would say education and training is a big challenge. I still don't know why some university will still not offer medical physics in Nigeria, because it's really great, especially when they have the equipment. And then for the universities that offer it, they must be certified to be able to train people adequately. Do you have the right equipment? Are you going to take people through the right modules? Are they going to say, how will somebody be a graduate of medical physics and then you've never even seen a CT before? You've never even touched a CT before. You've never even operated. You don't even know what pitch is. You don't know what slice thickness is. You don't know what, you don't know what AEC is. I mean, it might be a bit tricky to practice. You need a good foundation. So education and training, I've put that there. Regulatory infrastructure. Nobody wants to do what is right. Nobody's going to like your face as a physicist, because investors, people just want to buy cheap equipment, just want to, you see the nice building, but terrible equipment. We see that all the time. And if the regulation is not there to stop them, look at it now. Majority of hospitals will only reach out to physicists when they want to get their NRA license. The moment they get their license, they don't talk to you anymore. Limited number of qualified physicists is a challenge. Funding and equipment constraint. You want a good equipment, but the hospital does not have the money. What are you going to do? I mean, you are a physicist, but they are the one to bring it to cover out the money. Lack of integration in clinical workflow. Some people don't even know you exist. These are some of the things I personally experienced as a physicist practicing in Nigeria. You see people that are in your unit and you've been working there for 2 years and they see you in a general meeting and they're still asking you, sorry, what do you do as a physicist? So you have to keep explaining yourself all the time. So in conclusion, dear physicists are an integral part of imaging team, and our roles includes but not limited to QA, QC, radiation dose management, clinical support, training and education, equipment procurement and commissioning. I mean, this is not really a technical presentation. Maybe there will be more opportunities sometimes in the future to really come and to really discuss maybe quality control, maybe important tests to do, how to do them, dose management system, how we can manage what we have to achieve at least what we should have, and the rest of them like that. So thank you everyone for having me. Thank you, NAMP. I'm going to just stop it there. Thank you so much. Thank you. Over to you, Dr. Yobosa.
Thank you very much, Mr. Adedokun. See, I was smiling when you were talking about the